Dr. Sonu Goel is going to present his innovation on transscleral modified 4-point fixation. He's quite innovative with all the cortex sutures and all the various G kind of surgeries that I see. So let's see.
So thank you very much. I'll be just like to present innovation in disguise. So this was more of an accidental kind of a thought process when I was just operating. So an idea came, and this is, I name it as the transscleral fixation of a closed haptic design. I call it a 2-in-1 technique. So what actually does this mean is, you see this C-loop design, and accidentally whenever there is a PCR, you tend to suture the two haptics here, and then you try to fixate it transsclerally, something like this. So this is a kind of a 1-1 fixation, and usually most of the studies have shown that these lenses usually end up with lens tilt, so ending up with a large amount of astigmatism. So this is a single point of fixation that can be done with the 3-piece or these scleral supported lenses. So the idea came, and initially we were doing with Bausch & Lomb, but Bausch & Lomb we were trying to do a 4-point fixation. That means 2 sutures were being tied. So what I want to show here is that this IsoPure lens, since we've been using them, there was a closed library, I didn't have any alternative, I used it and ended up innovating something. So my point here is a very straight simple thought that this lens, taking these 2 points as points of fixation, and with the kind of support that they can help us, so the lens tilt can be prevented, and this could prove to be one of the very stable lenses when used for transscleral fixation. Whether you use a 9-Proline or an 8 Gore-Tex, this would work very well. So the whole concept came up, and this brewed up in my mind, and I came up with this kind of thought that यार इसमें से वीडियो हट गया, नहीं कोई बात नहीं, मैं पहले वो दूसरा वाला वीडियो शो कर दूंगा. So this is what happened to me in the OR, and so this was a patient, trauma, post lensectomy, post vitrectomy. There was a foreign body which was removed, and there was an IOL which was placed. So initially we thought that this was a dangling lens, and it was a Rayner loop design which appeared to us because the lens was trying, the lens we could not make out the haptic. So we took this patient, and we thought that we'll transfix the same lens. But unfortunately, as I was just passing the suture, I realized that this was again a C-loop design. And to the best part of it, I was operating the VROT, and there was no support of infusion at this time. So just watch carefully, this is a C-loop design, so we thought of just explanting it. So I have made an Hoffman pocket here, and I did a Hoffman pocket on the opposite side, 180 degree. There was no Gore-Tex available, so I ended up using 9-Proline here. So the straight simple, passing the loop from both the ends. So I took this lens inside the injector and just stopped here. So just the 2 haptics, and then this 9-Proline would pass from one end, loop inside, and then exteriorize from the other end. So it's a simple loop within the closed loop design of this IOL. And then, with a 26 gauge needle, 9-Proline is trail tracked, and from the opposite end through the Hoffman pocket, I exteriorize it. And now slowly, I roll this lens inside. The incision is close to 3.5 here, and push the lens. The leading haptics are already supported, so there is no chance of the lens getting down. And then I slowly rotate the lens onto the iris. So the trailing haptics, and now the 9-Proline goes, just watch carefully, from one of the holes here, and I trail track from the opposite side, exteriorize, and then ensure, without engaging any corneal tissue here, I again trail track. So the 26 gauge needle comes through the hole within the loop, and then I trail track this 9-Proline, and then exteriorize. So I think within minutes I could achieve this transscleral fixation, a a rock stable lens inside the eye because of its unique design. And this is how I pull the nitrochlorine from the Hoffman pockets on either sides. Ensure that the lens is in the center. Never need to titrate before putting a knot. So ensure that the lens is in the center, and I think the Lumera, the 3 Purkinje images are a good aid to the centration. And the second stage was to prepare the iris. The iris tissue was deficient all around. But on the first stage, we didn't have an access to the prosthesis. So we thought of going in the second stage. So buried inside and buried this side. Now gradually I'm trying to suture this here. On the opposite side, just titrate and never too tight. And that brings to a very well centralized transclerally fixated IOL. And this is how the picture of the slit lamp, this is how the lens centration looks like. And this is how day one post-op picture. The lens you see here, it's almost as if it's inside the bag. So we did an OCT and we did the refractions. There was hardly any cylinder, but there was an error of -1 because of its location, a little anteriorly. But all in all, we were very happy with this kind of technique. Thank you. I think the animation is not working. I would have shown the animation here, but unfortunately, no. Okay.
Very nice, Dr. Sonu. And I mean, the problem with these IOLs is that you can't, usually pre-pass a suture. So what you've done is innovatively, you kind of let the IOL protrude from the tip,
So
pass the suture, and then inject it. So that makes it easier because you've already been able to pass the suture, which otherwise it's very clumsy, and you can have a broken suture, you can have an entangled suture if you try to pass before you put it in the injector.
Correct.
So I think that you've been able to override that, and then
there is no knot inside.
Right.
So that's one, and then it can be titrated because you can pull one end, on either ends you can just titrate. So
nice.
actually, the most important part is the tilt component and the centration, which I thought is achieved on this case. So many more cases to come, and using 8 Gore-Tex, we'll publish this.
Right. Also, I wanted to ask you that you have to make your incision like maybe 0.2 mm bigger, because once the IOL tip is kind of opening up a little bit in the front, so it won't engage, right? You must have
correct. So I made it 3.5.
Right. So that's fine, because that is still a self-sealing and nice wound. Anything, Dr. Ajay or Dr. Ashish?
No, it's really nice, and the only thing what I want, because the haptics here are little friable because of the material, unlike the 3-piece lenses and all. So you feel that stability of the haptics and tilt and all. This is one case what we have seen.
That is equivalent to a 4-point fixation now. So there are 2 points on the sclera and the 2 points inside with a width of the kind of separation that they have.
Normally with the pull, the haptics are going to be pulled here. So because these are
but these are relatively quite stiff, as well as fragile, not too very fragile, but I think they're going to stay.
No, very skillfully managed, and I think that's what I was going to say. I think it has the advantage of a 4-point fixation with the not the whole rigor of
kind of a single loop system.
Single loop system.
Yeah, exactly.
Makes it simpler.
So I think this lens can be used, internationally, and a lot of studies on this for transcleral fixation. Yeah.
True.
A very easy technique.
Nice.
Thank you.